Before I begin my presentation, I would like to thank Susan Spiegel and Tanya Cintron from our development department who helped with all of the logistics behind today's symposium. As David mentioned, I'm going to talk about hemodialysis care advances and improved outcomes. I'll start with a brief history of hemodialysis at the Rogosin Institute. In 1957, Albert Rubin, who you see pictured here, founder of the Rogosin Institute, performed the first hemodialysis treatment for chronic kidney disease in the New York metropolitan area. In 1963, the Rogosin Institute, in collaboration with what at the time was the New York Hospital, now the New York Presbyterian Hospital, performed the first kidney transplant in the New York metropolitan area. At that time, dialysis was seen as a bridge to transplantation. It was only available to those who were, quote unquote, most likely to contribute to society. That meant patients with families, patients who were anticipated to return to work once their uremia was treated, and patients with the means to pay for dialysis. There were few machines available to provide dialysis, and priority was given to white men. Proximity to a dialysis center was also required. Dialysis was not available in underserved communities. And again, I want to point out Dr. Rubin and Dr. Stenzel here with that first patient to receive the kidney transplant at Cornell. In 1968, Rogosin opened its first treatment center for patients with chronic kidney disease. To reduce the burden and expense, Rogosin's home dialysis program grew dramatically. In fact, more patients were dialyzed at home than in dialysis centers. As we'll talk about in a moment, after Medicare was expanded to include patients with end-stage kidney disease, prevalence of patients on dialysis and their survival expanded. In 1977, Rogosin opened the state-of-the-art dialysis center in the Guggenheim Pavilion, which you see pictured here. Over time, the home program essentially vanished because of improved reimbursement for in-center dialysis. But in 2001, Rogosin developed a novel program for home nocturnal hemodialysis, employing the concept that more dialysis is better. Currently, Rogosin provides maintenance dialysis to some 1,400 patients at 10 centers in 4 boroughs of New York City. 20% of those patients treat by home modalities, including peritoneal dialysis and home hemodialysis. In terms of looking at the prevalence of patients with end-stage kidney disease in the United States, as you can see here, in 1983, when the Rogosin Institute was founded, approximately 50,000 patients were receiving maintenance hemodialysis in the United States. Virtually all of them treated in dialysis centers, and few patients had successful kidney transplants. Today, as you can see, approximately 500,000 patients receive maintenance dialysis, and almost 50,000 receive peritoneal dialysis. And you can see the enormous growth in transplantation in the blue line here, so that now close to 200,000 patients have functioning kidney transplants. So where did this payment system that we have today come about? It began in the summer of 1971 when the Senate Finance Committee, led by Senator Vance Hartke, who you see here, a Democrat from Indiana, introduced Senate Resolution 3210 to provide for the establishment and operation of programs and to provide financial assistance to individuals unable to pay the costs of necessary treatment. Representative Wilbur Mills, who led the House Ways and Means Committee, held similar hearings about payment for dialysis. Those hearings included presentations by a number of kidney patients, including this gentleman whose name was Shep Glazer. Mr. Glazer presented to the House Ways and Means Committee on November 4th, 1971. And some of the testimony that he gave was that he was 43 years old, married for 20 years, with 2 children, ages 14 and 10. I was a salesman until a couple of months ago. To supplement my income to pay for the dialysis supplies, I tried to sell a non-competitive line and was fired. What should I do? Sell my house and go on welfare? Should I go into the hospital? Then I cannot work. If your kidneys failed tomorrow, wouldn't you want the opportunity to live? And that testimony was very dramatic to Congress. The highlight of the congressional hearings was that Mr. Glazer actually had a dialysis treatment on the floor of Congress. The treatment lasted only about 5 minutes, and then it's not entirely clear to me what happened. I've heard that there were some technical issues or some clinical issues that caused the treatment to end. But that treatment was very dramatic and led to articles like the one that you see here from the New York Times. Representative Mills introduced House Resolution 12043 on December 6, 1971, to amend the Social Security Act to provide financing for individuals with chronic kidney disease. Ultimately, a conference committee between the House and Senate passed Hartke's amendment on September 30th, and the bill was signed into law by President Richard M. Nixon, who you see here, on October 30th, 1972. At the time, there were some basic misestimates of the cost of dialysis. Principally, the misestimates involved the incidence and prevalence of patients with end-stage kidney disease. Senator Hartke based his cost estimates on information from the National Kidney Foundation. On September 30th, 1972, he testified that he estimated that the deaths due to kidney disease cost the U.S. $1.5 billion annually in lost income, and that the U.S. was spending $1 billion annually on direct patient care for a deficit of $500 million to the U.S. budget. They also estimated that of the 55,000 Americans with chronic kidney disease, only 20 to 25,000 were considered candidates for either dialysis or transplantation. They also anticipated that technology and transplantation would reduce patient costs further, and that most of the patients who received dialysis would return to work and therefore come off the Medicare rolls. The preliminary estimates at the time were that the program would cost $250 million over 4 years and would be covered either by a surplus in the hospital trust fund or an increase in the Medicare tax. Note that these estimates did not include the cost for patients over the age of 65 because they were already covered under Medicare benefits. Well, you can see what has happened to those estimates today. And this is 2020 data, which is the latest data that is available from the USRDS. In 2020, Medicare expenditures in total were $608.7 billion. ESR spending on end-stage kidney disease was about 6% of the Medicare budget, or about $37.1 billion. Since 2012, CMS has made efforts to reduce the cost of the chronic kidney disease program. In 2012, they introduced the Quality Incentive Program, in which facilities can earn back 2% of their payments for quality performance after they're withheld pending quality results. In 2015, CMS introduced the Comprehensive End-Stage Renal Disease Seamless Care Model, the ESCO model. Dialysis facilities and their physician partners were responsible for the total care costs. Of note, hospitalizations were reduced by 3%, and Medicare spending was reduced by $217 million, or about 1.3%. The savings were driven principally by Wave 1 participants due to fewer mistreatments and emergency treatments and greater rates of optimal dialysis starts. And you can see that savings here for those facilities participating in the CEC model and a comparison group here. In 2021, CMS began the End-Stage Renal Diseases Treatment Choices Model, a mandatory model in which a third of dialysis facilities in the US are required to participate. The program, as you can see outlined here, will consist of both positive and negative payment adjustments that in year 5 of the program in 26-27 will reach 10%. Adjustments are then based on both home dialysis and transplant rates, as well as quality measures. When we say that more dialysis is better, just to give you a sense, when the kidneys function normally, they process over 10,000 liters of blood per week. Standard hemodialysis, by comparison, processes only about 360 liters of blood per week. Peritoneal dialysis does significantly better, processing about 1,000 liters per week. And home hemodialysis, at its best, provides about 750 liters of clearance per week. Obviously, in a patient who receives a kidney transplant, they may have about half of normal kidney function, but still considerably more than what patients who are treated by dialysis receive. But it's difficult to compare outcomes of different dialysis modalities because some patients who are treated by in-center hemodialysis are poor candidates for home dialysis therapies. And there's also an important association between resources and social supports and choice of dialysis modalities. When we try to compare, we take data from the USRDS, which you can see presented here, comparing hemodialysis and peritoneal dialysis. And this is looking at survival probability. And you can see that there's minor differences between hemodialysis and peritoneal dialysis, but that there are significant differences. For example, in patients starting dialysis in 2015, who started on peritoneal dialysis, 46.5% were alive at 5 years, compared to only 41.7% of those who started on hemodialysis. And taking those numbers a bit more granularly, you can see improvements in survival in all modalities, but more notably for peritoneal dialysis, which does continue to do better than hemodialysis. And clearly, when you look at patients receiving kidney transplants, they do far better than any mode of dialysis. Here we're looking at 5-year survival in patients with deceased donor kidney transplants, which approaches 83%, and those receiving live donor transplants, it's 93%. In terms of hospitalization rates, the admission rates for all patients treated by dialysis have decreased over time, as you can see here. But hospitalization rates are nearly identical, again, as you can see here, for patients treated by hemodialysis and those treated by peritoneal dialysis. Clearly, those with kidney transplants have much lower hospitalization rates. Readmission rates, in other words, admission within 30 days of discharge from the hospital, are higher for patients treated by hemodialysis compared to those treated by peritoneal dialysis. Much of the improvement in hospitalization rates has been due to improvements in hospitalization rates for those with cardiovascular disease and those with infections. Most of the improvement has been due to decreases in vascular access complications, but rates for cardiovascular disease and infection have increased. Again, data from the ESCO model showed that hospitalizations could be reduced by active management, especially for patients with fluid overload and other complications from missed dialysis treatments. As part of our participation in the ESCO model, Rogosin developed the PEAK program, and you'll hear more about that from Ms. Edwards later. The PEAK program emphasizes health literacy under the supposition that patients want to learn more about their care options, but that they need to receive that information in an educationally and culturally appropriate manner. Patients with GFR less than 30 milliliters per minute per 1.73 meters squared are eligible to participate in the PEAK program. PEAK, as you can see outlined here, is a multidisciplinary education program with 2 overarching goals: to improve decision-making regarding kidney replacement therapy, that is, to increase the rates of transplantation and home dialysis, and to improve optimal dialysis starts by increasing rates of vascular access creation and outpatient dialysis starts. In operation, patients entering the PEAK program have a meeting with a nurse practitioner and a nurse educator that lasts for up to 2 hours and is focused on kidney disease, the purpose of the program, and care options. And then the care team holds a weekly care plan meeting to discuss each patient's clinical status and ensure care coordination. So how has the PEAK program fared? This is data through December 31st, 2022. More than 500 patients have had an initial evaluation. Of those who've required kidney replacement therapy, 13% of PEAK participants have had a preemptive kidney transplant, compared to 3% in the USRDS national data. Almost 30% of patients have started on home dialysis, and that's a combination of peritoneal dialysis and home hemodialysis, compared to 13.3% nationally and less than 5% across New York City. Of PEAK patients starting in-center hemodialysis, over 50% have started with a fistula or a graft as an access, compared to less than 20% of the USRDS registry. And in terms of optimal starts, which are defined as either an outpatient start with a fistula or graft, home dialysis, or a preemptive kidney transplant, nearly 2/3 of patients participating in PEAK have had optimal starts, compared to only 20% of the USRDS registry. And here you can see the rates of in-center hemodialysis in blue, peritoneal dialysis in green, and home hemodialysis in yellow at Rogosin. You can see that during the height of the pandemic in 2020 and 2021, our home dialysis rates increased significantly. In the last year or two, many of the home patients have been transplanted, resulting in an increase again in our in-center hemodialysis program relative to peritoneal dialysis and home hemo, but still we're doing better than we did in 2018. Rogosin is now working to expand our PEAK program. Our home dialysis rates are notably much better in better resourced communities. So we have worked to expand our program to underserved communities in Brooklyn and in northern Manhattan. In 2021, Rogosin received a grant from the Llewellyn Foundation to support the establishment of the J. Bruce Llewellyn Wellness Center, which will be based in East New York, Brooklyn. There are three pillars to the program. One is a new PEAK program at our Brookdale campus. The second is a new home training program at our Brooklyn East Center on Linden Boulevard. And finally, an expansion of our Wellness Ambassadors program. And you see our Wellness Ambassadors pictured here, and you'll hear more about this program from Dawn Edwards in a little while. In 2022, Rogosin partnered with Columbia Nephrology to apply for a grant to expand our PEAK program to Washington Heights. The program has been supported by the Dalio Center for Health Justice of New York Presbyterian Hospital, and we've employed bilingual staff to continue to attend to the culture of the community. Some of the other innovative work that Rogosin is doing includes a behavioral health program. Depression, anxiety, and insomnia are common in patients treated by maintenance dialysis. And our data has shown that anxiety correlates with worsening physical symptoms in this patient population. And that work was led by the director of our behavioral health program, Dr. Daniel Sukor. Of note, the COVID-19 pandemic created great stress and anxiety and worsened pre-existing symptoms for both our patients and our healthcare workers. Many healthcare workers have experienced compassion fatigue, which has caused some to step away from clinical care, and others have continued to power through. Our behavioral health team supports our patients and staff to help manage these symptoms. As part of the American Society of Nephrology's COVID-19 response team, our team, working with two of my colleagues who you'll meet in a little while, Dr. Jeff Pearl and Dr. Vanita Kumar, helped to create a mental wellness resource, which provides self-guiding tools. And that resource can be accessed at this website. Other work that we're doing in terms of symptom management includes efforts at pain management. The PRUNE study, which is being led by Dr. Tani Berman, is a collaboration with the Division of Palliative Care and Geriatric Medicine at Weill Cornell. And we're also participating in an NIH-sponsored clinical trial of transcutaneous neurostimulation for neuropathic pain syndromes. We're also participating in the Kidney Scholars Teams program, which is a collaboration with the Coalition for Supportive Care of Kidney Patients, and is supported by the Fan Fox and Leslie R. Samuels Foundation. It's a case-based education program to teach dialysis clinicians primary palliative care skills across the spectrum of kidney disease. Some of the topics we've discussed include CKD transitions, symptom management, patient non-adherence, substance abuse, mental health, and end-of-life care. In terms of improving outcomes, again, survival in kidney patients has improved since 2010. But in 2020, there was an alarming increase in deaths among kidney patients, largely due to COVID. The factors known to be associated with higher death rates in kidney patients include age and black and brown skin color. Infections are the second leading cause of death in kidney patients, as you can see here. And the most common types of infections that kidney patients face include vascular access, primarily catheter infections, septicemia, and other preventable infections. In our effort to reduce the rates of infections, Rogosin is participating with the American Society of Nephrology in an adult immunization project, which is a learning collaborative to try to increase the rates of immunization in kidney patients. We're also participating in the Human Factors Project with the American Society of Nephrology. The Human Factors group came out and visited Rogosin the end of last week to evaluate our PD program and help us understand the factors that increase the risk of peritonitis in patients treated by PD. Finally, in collaboration with Dr. John Lee at Weill Cornell, we're participating in a nasal microbiome project. And what we've identified is that there are correlations between the nasal microbiota and peritonitis infections in patients on peritoneal dialysis. And now we've expanded the program to look at patients on hemodialysis to see if there are correlations there as well.